Nice to see you all back over here again. Thank you all for taking the time off to actually come here. Following that, we'll be starting off with our series of lectures on Gastroesophageal Reflux Disease, which is the theme of the evening. And for that, I would like to introduce my team over here. So started by Dr. Tasmia Papa, latest addition to the surgical team. She's a laparoscopic and robotic surgeon specializing in upper GI and bariatric. And then Dr. Dharmendra, who's the head of the surgical department, and followed by our dynamic superstar gastroenterologist, Dr. Shubha. We'll be talking about endoscopic management of reflux. And then Dr. Nabil will be joining me as well. He's also a laparoscopic surgeon. So I'd like to hand over the mic to Aditya to start off on his interesting orthopedic case.
Presenting a case to the elite crowd like this, I would like to thank the family of Lifeline for inviting me. So today I'm going to talk about a case that I've come across recently. In our career, we come across a lot of cases, but only few cases will stand out and make us remember even after a while. Today I'm going to talk about one of such cases. So it's called A Funny Bone, Where Are You? So on a Saturday evening, I got a call saying that one of the patients has suffered a fall and injured their left non-dominant hand. Lady is 35 years old with no external wounds, and she was obviously in a lot of pain and difficulty to move the wrist. I was thinking, yeah, because she has sustained an injury, she should not be able to move the wrist and all. But I was specifically told that she was not able to move her index and middle finger. That looked a little peculiar to me. Then I took a look at the hand, and it looked like this. And I was wondering what that pointing tent over there on the dorsum of the hand. And then we took an X-ray. There is no external wound, but there is a bone missing there. I was thinking, where'd the bone go, where'd the bone go? And then there it was. It went in a very weird way onto the dorsum of the hand and lodged in between the index finger and middle finger. Nobody knew how it went, and it was a very, very freaky thing to look at. So what next? What were the ideas to deal with this? Because this was not a standard protocol case. It was not a defined orthopedic case that is in the textbooks. So we were contemplating what to do. The bone is broken and it is somewhere in the dorsum of the hand. So I was thinking of three ideas. One, open the hand on the dorsum, take out the bone and put it back through this way and attach it to the hand. And one more thing, to a Dirac procedure. That means just taking out that bone and just discarding it, because anyway it is cut off and all the blood supply is gone, and just leave it like that. Or one unusual thing that I thought of was, why don't I open it here, retract the part that it has formed and pull it back down and then reattach it. So these are the three things that I was thinking of. Even till I went into the operation theater, I didn't fixate on what to do. But this, finally what I thought was, in the 6 compartments of the extensors in the wrist, it found a way in the 6th compartment, the ulnar bone, which just got lodged there in this place, this bone. It was supposed to be here. It found a way and went till here. So I thought I'll retract that path and pull it back and fix it back in the position. So I just went in, carefully dissected the extensor carpi ulnaris and did not injure the tendons on the way, brought it back into position and fixed it with plates and K-wires. And finally, the patient follow-up was really good. The patient had a very good outcome, and after 3 months, she was able to go to gym and do all the exercising activities. So what was different about this case? One, this is not a textbook defined case, and I had to think of a different way to treat this. And what was the challenge was to plan the surgery. The planning of the surgery is everything. Preoperatively, you do everything, and you have to arrive at a plan, and you should not be going in with a blind mind. So how could it affect? I was thinking, because it's a dorsal part, it did not injure any artery or any nerve. If it was on the ventral part, it would have injured the ulnar nerve or median nerve or the radial artery, God knows what it could be. But post-operatively, the patient was very happy. All the finger mobilizations were done and the wrist movements were full, and the patient is satisfactorily back to normal life now. Thanks for listening.
So next we'd like to get into our main topic of very, very commonly faced problem by almost every general practitioner, physician, obstetrician, surgeon, medical gastroenterologist, whatever it is, you will be facing this issue among your patients. So this is gastroesophageal reflux disease, which we will be splitting into 3-4 parts like I told you earlier. And we'd like to start it off by the first part, that is the basics and the pathophysiology of GERD, which will be taken by Dr. Tasmia and followed by Dr. Dharmendra.
With the team from Lifeline, we're going to present about gastroesophageal reflux. This is a very common problem, but it's often overlooked and frequently undertreated. So, moving on, I will be talking only about the pathophysiology of GERD. So, what is GERD? It is basically a retrograde movement of the gastric content through the lower esophageal sphincter into the esophagus. So this is common in most people. So it is called a physiological reflux if it occurs only after meals. It does not cause any symptoms, and it is of short duration. So when do you call GERD pathophysiological? It is when it occurs in frequent episodes for longer duration. It occurs anytime in the day or night. It's not related with meals. And it may produce symptoms and inflammation and mucosal injury of the esophagus. So these are the main etiology for GERD. The most common is the transient lower esophageal sphincter relaxation. So this is where the LES relaxation is unrelated to the swallowing, which occurs for more than 10 seconds. Incompetent LES, this can be because of the decreased LES pressure, decreased overall length of the lower esophageal sphincter, or a less abdominal LES. So another etiology is the deficient or delayed esophageal acid clearance. This is because of a peristaltic dysfunction. So here I'd like to talk about non-reflux esophageal disease. This happens when the patient is having symptoms of reflux, but on endoscopy there are no findings of mucosal erosion. So just to summarize, we have an impaired esophageal clearance. Another cause is hiatal hernia, transient or inappropriate relaxation of LES, reduced resting pleasure of LES, delayed gastric emptying, and another important cause, pyloric incompetence causing duodeноgastric reflux. So what happens? So when all this etiology happens, there is an acid reflux event. But something happens in the middle before the actual event of the heartburn. So what happens is there is a dilation of intercellular spaces which causes an increase in paracellular permeability, and hence there is heartburn. So the clinical spectrum of GERD, it starts off with a physiological reflux, then it moves on to symptomatic GERD, where you have typical symptoms and atypical symptoms. In typical, you have the usual heartburn and regurgitation. Atypically, you have chest pain, dysphagia, cough, asthma, laryngitis. Then it moves on to esophagitis with the mucosal injury and Barrett's, a complicated esophagitis. So here I just like to mention a little about gastrocardiac overlap. As anginal pain is the most common differential for GERD, how do we differentiate it? So the visceral efferent from the T1 to T4, it supplies both the pericardial layer as well as the esophageal mucosa. And this is the reason why most of these patients of both the groups, they have very overlapping symptoms. So the main way to differentiate this is obviously by ECG and symptoms. So it's important to differentiate anginal symptoms versus a normal GERD symptom. So anginal pain is short-lasting, it's about 2 to 3 minutes, aggravated by exertion, exercise, relieved by rest, and sublingual nitrates. And symptoms will be inappropriate diaphoresis, giddiness, dizziness, palpitations, and syncope rarely. So usually patients with anginal pain, they have an antacid, and they assume that their pain is not relieved because of the antacid. But most commonly in anginal pain, it would have been relieved because the patient would have taken rest after the pain. So it's very important to evaluate the cardiac aspect in these patients. And so basically, there are 3 unique groups for GERD. One is, like I've already mentioned, endoscopy negative reflux disease, where the patient will have atypical or extra esophageal manifestations. The classic erosive esophagitis, where there is an ulcer or a stricture and also bleeding in some patients. And Barrett's esophagus, which will predispose to adenocarcinoma of esophagus. This is just a current definition for non-erosive reflux disease. This is in patients with classic symptoms of GERD and normal esophageal mucosa. Next, I'd like to call upon Dr. Dharmendra to elaborate on the workup for GERD.
So today, everywhere, a lot of patients complaining about gas, dyspepsia. I have some bloating, belching. It's a complex scenario of symptoms. So in this, mostly, as a physician, we won't work up properly. So that lead to very dangerous complications like patient ending up with cancers or other serious problems. See, nowadays we are seeing like a 28-year-old man having a gastric cancer. That too in an inoperable stage. So we are thinking, okay, a lot of gas and some dyspepsia. We won't think of cancer in a 28-year-old man. So that's where we fail to investigate at the earliest. See, all these endoscopies, all the investigations, there may be negative result, negative findings. But if you pick up some early gastric cancers or like this reflux esophagitis at the earliest level, so that is the win situation for us also and for the patient also. So here comes the importance of the workup of any upper GI symptoms or any gastric ailments. We have to step one step forward and we have to move for the workup. So these are all the basic upper GI series we call. So in that, endoscopy is the first line. After that, 24-hour pH study and esophageal manometry. And in some cases, in this context, we will use CECT abdomen also. And ultrasound abdomen is very important to rule out gallstone diseases. See, gallstone diseases, ultrasound is the best investigations rather than CT. But of course, MRI is still better. So the gallstone symptoms and these ulcer symptoms, it will correlate, it will overlap. So in those situations, we rule out GB pathology also. So any upper GI series, we have to include ultrasound also. So as I mentioned, there is always a diagnostic delay. It is mainly because of physicians, we think there is an age limit. Okay, this patient, he won't have any serious reflux, any ulcer or Barrett's or any cancer. Ignore patient symptoms because of age. Because of younger age, we think patient won't have gastric cancer or any serious reflux disorders. So we underestimate his symptoms and we won't work up properly, ending up with advanced gastric cancers or advanced problems. So whenever patient has any weight loss, loss of appetite, and melena, it should be taken seriously. It may not be a classical GERD symptoms, so we should be aware of, okay, we should not treat like in the medical management of GERD, we should think something else. Patient is not having GERD, we should be careful, and he should be worked up properly. So why we should work up? First, to confirm the diagnosis. If you think, okay, diagnosis is GERD, we have to confirm, and we have to quantify the disease severity. Like we'll see the classifications. So, like how much, what is the grade of his reflux, on what stage, whether it proceeded to Barrett's, like this. We have to quantify the disease, and again they assess the severity that comes to the grade, and to plan for the treatment modality. So though the fundoplication is the standard line, there is subtle variations in the fundoplications. So we will tailor according to the findings of the upper GA series investigations. So we should not miss the set of investigations. So there should not be any surprise after entering into the abdomen. So there is always a scope for the endoscope. See, it is the main investigation that, see, usually we see patients, they will go to so many other places, they will do ultrasound on so many blood investigations, and ultimately the endoscopy won't be there. See, we are seeing in the room from outside how it is the room. Just enter the room and see, like this. See, that's what. See, that's where we miss the link. So that was why Japan and all in the forest countries, they are picking malignancies at the earliest stages, because they are doing a lot of endoscopies, like this. So the direct, you attack the target, direct, just to go and see. So you won't miss the findings. There should not be any surprises. And we can see the lot of grades of esophagitis, and we can diagnose the hiatus hernia. See, patient with the GERD symptoms with huge hiatus hernia, see, whatever the medical treatment, it won't cure the patient. See, anyway, he will have the symptoms. So without treating the huge hiatus hernia, we cannot treat his symptoms. So that diagnosis of hiatus hernia is also important. And to rule malignancy, see, always there will be some reflux in malignancy also, there will be some discomfort, some gas, everything. So sometimes in malignancy also, if we give PPI and prokinetics, the patient will feel better for some time. So we think he has some GERD and his symptoms are better. But the underlying malignancy is growing. So without endoscopy, we should not treat the patient. So this is the Los Angeles classification of GERD. So if you see, first is, that is hiatus hernia. The second B is that is grade A reflux esophagitis, that is less than 5 mm, and that is that C is grade B, that is that mucosal breaks are more than 5 mm, and grade C is, it is involving less than 75% of circumference, and grade D is more than 75%. Because these erosions, if it involves the more than 75% of circumference, you will get this stricture. Then it is very difficult to treat the patient. So in these cases, endoscopy and frequent evaluation, it is very important. So if we miss the bus at the earliest stage, then patient will end up in stricture and frequent dilatation. Treatment will be very difficult. That's what we should investigate at the earliest. This esophagitis, you can see the lot of erosions and ulcers. This is, you can see the stricture. So in these stages, it is very difficult. We have to rely on a lot of balloon dilatations. This hiatus hernia, you can see the gastric mucosa coming from. This is in this. This is advanced. This thing. See, patient developed metaplasia and this thing. After that, it went to the adenocarcinoma stage. So this we should not see. One patient, our teacher, Dr. Professor Rajkumar, he advised the patient to undergo this anti-reflux surgery like some 10 years ago. In the later stage, he didn't give consent for the surgery. After 10 years, she developed adenocarcinoma. See, this may be a rare incident, but they will be taking on pumps of PPI in the long run. But maybe it may be 1%, but for that patient, it is 100%. So that's where we should find the case early. We have to follow up, repeat endoscopies. We have to convince the patient this is the complication like this. See, 24-hour PH study. This is the gold standard investigation to diagnose GERD. Even though there is absence of mucosal lesions, there may not be erosions, there may not be any ulcers, but we can still find out the patient is having symptoms. And endoscopy wise, there may not be severe erosive esophagitis. But if you do 24-hour PH study, in obvious cases, this may not be necessary. But this non-erosive esophagitis, if you do 24-hour PH study, still you will get the percentage of reflux is more. So those kind of patients you can pick up very early before the erosion sets in. So this is the gold standard. Patient should be admitted one day in the hospital with a probe through the nose. Two probes one in the stomach and one will be in the esophagus. So it will calculate with a software device. So it will tell patient will be eating normally, and at the end of after 24 hours, it will give the record how much the reflux percentage. Usually we like less than 10%. It is normal, and more than that, we have to do some intervention, starting with the lifestyles and medications, and later on surgery. So if you see a lot of studies, the 24-hour PH study shows there are a lot of positive results. This is the normal graphics. So we have expert Dr. Shubha. He will explain more about this 24-hour PH study and manometry. So this is one report recently we got, we did in our hospital. The report will be like this, and you can see, sorry, it is not clear. The reflux is around 59%. So next comes esophageal manometry. If you do 24-hour PH or endoscopy, still we have to rule out the esophageal motility disorders. So if you see some patients, they will have esophageal submotility disorders. And if you add on a tight fundoplication, the results will be miserable. The results will be miserable. See, already there is submotility of the esophagus. The esophageal clearance is little poor. And if you add on the, of course, we won't do tight fundoplication. We will do always floppy Nissen's fundoplication. So if you add on fundoplication in the background of poor esophageal clearance, so it is, the surgery is always a functional, there is, the disorder is a functional. So see, it is not like gallbladder, you just remove the gallbladder, the patient will be okay. This is a functional disorder. So you have to carefully assess on basis of clinical symptoms and investigations. So you have to rule out the esophageal dysmotility before proceeding to the surgery. So we have to rule out the esophageal submotility. If esophageal motility is normal, then we can go for full-fledged fundoplication. In some case, esophageal, there is submotility is there, then we can adjust like top fundoplication, like it is not a full 360, it is like 180 or 270 degree. So it is everything, there is a basis. So patient having associated with some patients, they will present like aclasia also, it will mimic like the reflux. So we have to, the procedure is entirely different. We have to do Heller's cardiomyotomy. It is entirely different. So we should not miss completely in those patients. A patient is aclasia. So esophageal manometry is a test to assess the pressure, LES pressure and esophageal motility. So to grossly, it will avoid the gross errors in treatment. And to tailor the treatment, it is necessary. So our message is, so why we have to work up in a complex symptom scenario of dyspepsia. So we should pick up the disease, we have to confirm the disease, and we have to rule out aclasia also in case of if you use this esophageal manometry. And obviously we have to rule out any upper GI cancers. See, age is no bar. At any age, patient get cancer. That too, stomach cancers, it is very horrible. We cannot do anything. In some cases we have seen, we cannot do anything. We cannot, patients presented with GOO with ascites. See, with ascites, we cannot do FJ also. So there is no scope for FJ, there is no scopes of bypass also. So nothing will hold. So patient will rely on only TPN. That is end stage. This is because of diagnostic delay. We are all responsible. So on case selection depends on the workup. If some patients, they are all more like gastric symptoms, like bloating and delayed gastric emptying. In those cases, we will carefully avoid the surgery, because our main aim is to prevent the reflux. And patient is having full of bloating, full of other symptoms, means if you do fundoplication, it won't work. So anyway, we have to carefully, on the basis of history-wise and investigation-wise, we have to select the patient for surgery. So the workup will decide the type of procedure also, as I mentioned earlier. So thank you for patient listening. I will pass on the baton to Dr. Anirudh, who will explain the surgical modalities.
Okay, so that was an important topic, because it's very important to decide which patient needs to be treated by which modality. For that, the workup is very important, so we don't do the wrong treatment for the wrong patient. And that was explained by Dr. Dharmendra. And before that, I would like to really share that we're really happy that we have the great Professor C.M.K. Reddy sir in our midst over here, the teacher of teachers, one of the senior most professors in surgery, somebody who has taught almost every surgeon in the state, probably in South India itself at some point of time. And also we're very fortunate to have Dr. Anbarasu with us, who is currently the Vice President of the National Indian Medical Association, and he's been very closely associated with us for many, many years. He was one of the first few to have started the 24-hour health services with a nursing home nearly 30 to 40 years ago almost. And also we'd like to congratulate Professor C.M.K. Reddy sir, because he is just really about to release his latest book, one of his countless number of books, latest book on surgical embryology, and we're all waiting eagerly to have a look at it.
I think we see cases of GERD, but clinically we don't think much about it, honestly. I think a lot more cases are clinically missed because they don't have typical symptoms. Many patients come to us with a nocturnal cough, just a cough. And if the cough is dry cough, more in the night, because by gravity the reflux becomes more. It is almost, you can say that this is GERD. Particularly if the patient has no other corroborative symptoms to explain his cough. Very common. And of course, I don't know what percentage of the patients with GERD require surgery. Can you tell us, do you have any figures? Suppose you see 100 cases. How many of them you think require surgery, or how many of them you can manage medically? Approximately.
Maybe 10 to 20%.
About 20%. So 1/5, that is 4/5 of the patients. What I want to convey to you, because most of this group are not surgeons. Exclusively they are not gastric surgeons. So they should not go home with the impression that every patient requires surgery. No, it requires evaluation and careful monitoring and see if there is any evidence of developing complications. Then there is a reason for thinking of, but not every patient, because many patients do well with weight reduction, PPIs and anti-reflux medicines. A little bit of, there is always an emotional component is always there, these patients. So comprehensively, if you treat them, many of them get better. But the refractory cases definitely require investigation. There is no doubt about that. Thank you.
We're also very fortunate to have with us the MD of Hindu Mission Hospital, Tambaram, Dr. Vishnu Shankar. We're very honored to have you with us. Thank you so much for gracing the occasion. And also, before we proceed to the next topic, I'd also like to say a big thanks to Microlabs, for the manufacturers of Esofag D, Dolowin Spes, for having taken the trouble to invite the doctors and organize this whole thing after such a big gap of nearly 2.5 years now. So thank you, Microlabs.
That is what I meant. There is a place for the Esofag D.
Yes, of course.
That's what I meant.
Of course. Yes. So the next topic would be endoscopic management of GERD by Dr. Shubha, our medical gastroenterologist, one of the pioneers in Chennai who's doing a lot of endoscopic reflux treatment work.
At the outset, I would like to thank our chairman, Dr. Rajkumar sir, and Professor C.M.K. Reddy sir also for his presence here. And my good friend, Dr. Anirudh, thank you so much for this opportunity. So today I'll be touching on the medical as well as the endoscopic management of GERD. So the cornerstone with regards to the management of GERD, first and foremost, lies with the medical management. And there are a lot of newer innovations and a lot of newer intervention in the field of endoscopy in order to treat GERD, which can actually bridge the need for surgery. And it is right now coming up in a big way in many places in South India. And I would like to touch upon only the commonly done procedures for GERD. So this is the Montreal definition of GERD, which is nothing but a condition which develops when the reflux of the stomach contents causes troublesome symptoms and complications. So when is it defined as troublesome? It's defined as troublesome if they are adversely affecting an individual's well-being. So what we see in a OP basis clinically is only the tip of the iceberg, because a lot of PPIs and anti-reflux medications are available over the counter. So what comes to the attention of a gastrophysician is only a tip of the iceberg, which is why we actually need to work on people coming into us at the early stages of their symptoms in order to prevent complications like esophageal adenocarcinoma and Barrett's esophagus. So the prevalence in the West is around 10 to 20%, and in India it's about 8 to 19% based on the Gut Journal of 2016. So a little bit on the major physiological mechanisms which Dr. Tasmia has already highlighted upon. These are the protective mechanisms which protect our esophagus against the erosions caused by the acid reflux, the LES competence, the mucosal integrity, the clearance mechanism per se, and gastric emptying. So if any of these 4 major physiological mechanisms are affected, you are likely to develop severe GERD. So again, the syndromes or the symptoms can be classified into those with and without esophageal symptoms. Now, a lot of patients these days are coming up with extra esophageal symptoms, which include cough, which is mostly in the night, laryngitis or severe throat pain, and they consult multiple ENT physicians with no absolute relief of symptoms, and finally they come to us with a severe GERD. Exacerbation of asthma, especially in children, dental erosions also can occur. And the other associated symptoms could be idiopathic pulmonary fibrosis and recurrent otitis media. So the diagnostic tests earlier, barium swallow was considered as one of the gold standard, but not anymore. Endoscopy definitely has a role. Ambulatory pH monitoring, which is available with our hospital and we are doing on a daily basis. And this helps to give us a lot of information whether the reflux is as acidic or alkaline. So based on the acidic and alkaline composition of the reflux, we can decide the further management for the patient. And esophageal manometry, of course, in order to rule out achalasia cardia. So what is the role of endoscopy in GERD? So if the patient presents with dysphagia or dinophagia, involuntary weight loss, any history of GI bleeding or melena, or hemoptysis or hematemesis, and unexplained anemia. So on an endoscopy, if we find a mass or stricture or an ulcer, it's very easy to pick up a biopsy. And if it also helps in evaluation of patients with suspected extraesophageal manifestations of GERD. And endoscopy has a definitive role in patients with persistent vomiting. And also it is done as a follow-up of patients who undergo endoscopic or surgical management of anti-reflux procedures. Again, we classify the endoscopic appearance into non-erosive and erosive. So erosions generally are present in only 30 to 40 patients, whereas 60 to 70 patients have a normal endoscopy or a non-erosive endoscopy, which is when the 24-hour pH monitoring and the manometry has a role. I'm not going into the Los Angeles classification because Dr. Dharmendra has already explained to us. This is a picture of the 24-hour pH monitoring. It's a physiological study. It is done in an inpatient on a 24-hour basis. It quantifies the reflux in the proximal and the distal esophagus. It also gives us a lot of information whether the reflux is acidic or alkaline. And based on the DMISTer scoring, we offer the patient either medical management or surgical management. Now moving on to the management of GERD, the first and foremost management which we always stress is lifestyle management. Weight loss, and especially patients who are obese or overweight can actually do well with weight loss, head end elevation at least to 30 to 40 degrees, and avoidance of meals at least 2 to 3 hours before bedtime. So lifestyle changes play a definitive role in the initial management of GERD. Following which we can give them an 8-week course of proton pump inhibitors once a day. If they do not respond to proton pump inhibitors following 6 to 8 weeks, then we have to increase the dose, step up the dose, or add a prokinetic. And finally, if they continue to have symptoms despite all these medications, then endoscopy and 24-hour pH monitoring has a definitive role. So refractory GERD, again, we have to monitor, and depending upon the reflux monitoring, we either take them off medications and offer them endoscopic management or continue medications. So what are the effectiveness of medical therapies? So generally about 10 to 20% patients respond to lifestyle modifications. H2 receptor antagonists have a definitive role. 50% 5% of patients become asymptomatic at the end of 8 weeks. And single-dose PPIs these days have a fantastic role in GERD management. 80% to 90% are asymptomatic at the end of 8 weeks. And once we step up the role of PPIs, then close to 100% do not have symptoms at the end of 3 months. So the lifestyle modifications, again I repeat, are the cornerstone of GERD therapy. Modify your diet, eat more small frequent meals, and avoiding of fatty food, mint, caffeine, and alcohol closer to bedtime definitely has a role. And weight loss definitely will help in the management of GERD. So a little bit on the drugs, antacids, H2 receptor antagonists, and PPIs which are available over the counter, and of course prokinetics. These are the commonly available drugs and the normal doses. Now moving on to the step-down approach and the step-up approach. Depending upon the severity of symptoms, we can offer them either double-dose PPI at the outset or start with an antacid and move up the ladder and finally order double-dose PPI after 8 weeks. So these are the other examples of prokinetics, which include domperidone, etopride, levosulpride, and citalopram. Now, what is the intervention beyond medical therapy? So we have a lot of patients who do not respond to H2 receptor antagonists and proton pump inhibitors, and at the same time, they do not want to undergo surgery. So in such patients, what do we offer? Right now, a lot of intervention into the endoscopic management of GERD. So we have several therapies available, which is the EndoSinch, the RFA, endoscopic surgeries, LINS, EndoStim, and bipolar electric current. I'll just be touching upon the commonly done ones which are available right now. So this is called the Stretta procedure, or the radiofrequency ablation, where using a halo system, the catheter is introduced to the lower esophageal junction, and this helps, the radiofrequency current helps to enhance the tissue at the anatomic GE junction. So this has a definitive role in treatment of GERD, and 40 to 50% of patients have turned out asymptomatic at the end of about 4 to 5 sessions. On to the EndoSinch. This is again like how we do the fundoplication. This is a fundoplication done via endoscopy, where a suction of tissue just beneath the Z line is taken and the suture is applied via the endoscope, which is a dual channel therapeutic endoscope is required for this. Now moving on to the esophagus, which was FDA approved in 2007. Again, this is a transoral incisionless fundoplication, and this is again the application of the plication at the esophagogastric junction. So it helps to tighten the GE flap. So it requires again the candidates to be younger, in a good health, and generally early results are seen, but long-term studies and randomized control trials are definitely required in follow-up to actually suggest it at the outset. So injectable materials again are often injected in the GE junction, like radiofrequency beads and certain glues and all that. Initially they were very attractive, but now they are not FDA approved. So this is what is commonly available and done in many centers in South India, which is the Muse. It is nothing but the Medigus ultrasonic surgical endostapler. So it is imported from Israel, and it's an endostapling technique where the fundoplication is done via the endoscopic route. Again, we have a GERD-X, or the endoscopic full thickness plication. This is easily available right now, and this is again imported from Germany, and it's just a day care procedure done within a couple of hours, and almost you don't require to follow up the patient because the results are amazing with GERD-X. So this is the GERD-X device, and all you require is a therapeutic 180 channel endoscope. This is a third space endoscopy which is done. It's called the ARMS procedure. It's an anti-reflux mucosectomy. So with patients with a very lax GE junction, using a cap, the muscle is taken in and a stapler is applied, and this helps to again give a very pliable and very good lower esophageal sphincter, so the chances of reflux are also reduced. So finally, the take-home message here is GERD, again, a very, very common problem, and usually history taking is sufficient. So investigations are required only to document and do some therapeutic procedures. Endoscopy is again highly useful, so please offer endoscopy at the outset to all patients, and you need a 24-hour pH probe to confirm. So PPI and lifestyle modifications remain the cornerstone of the medical management. There is no two ways about it. Lifestyle modification and PPIs generally the patients do very well. And endoscopy therapy now is coming in a big way, and this can bridge the unmet gap between PPIs and surgery.
To answer Sir's question, in the first presentation that we had, Dr. Tasmia had put up a slide which had differentiated the presenting features of anginal pain and reflux pain. So though it is characteristically different, a patient will obviously not be able to differentiate it. It will seem the same. So what we tell all our patients who come in with that chest pain, almost all of them would have had some kind of emergency cardiac workup. Almost every second patient who's had severe GERD will come to us with a complete cardiac workup, including ECG, echo, sometimes even an angiogram. So what we tell the patients is the cardiac event can potentially be fatal, not the GERD. So it's important to do the cardiac workup first. So once that's ruled out, we will proceed with a detailed esophageal workup. So that is the safest way to go about it. Not all of them, maybe even less than 10% of them might be candidates for surgery itself, or might be candidates for workup for surgery. So not all of them would require. So that's something which we do on a daily basis, because we've been doing 24-hour pH studies and manometry tests for the last 20 odd years since Dad started doing fundoplications back in the late 90s. And because of that, our center's got one of the largest volumes of anti-reflux surgery. And just for that reason, because we've been doing this for many years, we get a large volume of those. Otherwise, it's still a relatively rarely done procedure. And I'll be going in detail about surgical management here. So when do you know that a patient requires surgery? So what is the need for this surgery? To relieve the symptoms. Very severe GERD, very severe heartburn, not at all responding to 8 to 10 weeks of proton pump inhibitors. Most of our patients come to us for GERD workup after nearly 5 to 10 years of purely antacids and PPI treatments. And at that time, we have to proceed to the next step. And as all of you know, we cannot take any chances in this, because it's an increasingly litigious environment for most of us doctors. So we will need to at least advise them for all the possible options. Whether they take it or not, it's up to them. And then to heal the esophagitis. When you have an endoscopically proven grade B or grade C esophagitis, when it's that bad, that means obviously the PPI is not working. So in that case, what else can you do? You'll have to step up the treatment to potentially an endoscopic or a surgical management. And then to maintain remission. So this is a functional procedure which we do surgically, and we'll have to make sure that the patient follows up regularly to make sure that it doesn't come back. And that's called maintaining remission. And then you have to treat the complications of surgery. So like Dr. Dharmendra had mentioned, 1 in 1,000 patients with severe GERD would potentially develop Barrett's esophagus, which is a precancerous, malignant or pre-malignant transformation of the mucosa of the esophagus, which can then potentially become an adenocarcinoma. So our severe esophagitis, which can then lead to strictures, grade C, grade D esophagitis, which then becomes quite tricky to treat. So why do you want to let it go that far? When a patient's got reflux for so long, which is not responding to medications, you'll have to go for the further workup. So what are the issues, the indications? Efficacy, safety, durability, compliance, and relative cost. So as most of you people would know, the endoscopic treatments are much more expensive. And because they are still relatively a little bit newer, the chances are that unless done by the experts, luckily Dr. Shubha has a pretty big number, but most of the other endoscopists who are just starting off with this, many of the medical gastroenterologists who start off with this, will not be able to give the desired results. So whereas A surgical procedure is a time-tested procedure, and if endoscopic management fails, they will have to come for surgical procedures anyway. And then longevity, there have been enough studies for the last 60 to 70 years, ever since Nissen, Bell C. Mark had all done the open fundoplication back in those days. I'm sure Professor C.M.K. Reddy sir will remember how morbid and gruesome an open fundoplication procedure is. As compared to that, we do most of our laparoscopic and robotic fundoplications in which the patient goes home the next day with hardly 3 to 4 tiny scars. And at our center, we do a large number of these procedures through just the belly button, called as scarless procedures or single incision laparoscopic surgery. So the indications, as I had mentioned before, failed medical management, patient preference for surgery despite medical management which is successful. So the patients would just say, I want it over and done with. I don't want to have any future complications like Barrett's or strictures or adenocarcinoma, etc. Complicated GERD. So if it's so bad, causing a lot of severe nocturnal cough, many of these patients will not even be able to lie flat. Many of them will have severe laryngitis, severe esophagitis, severe nocturnal asthma, as they call it. And then they can develop pulmonary fibrosis due to repeated micro aspirations of the acid and alkaline contents. And then large hiatal hernia. So when the hiatal hernia is that big, the treatment would definitely be a fundoplication. So hiatal hernia is something which can be found pretty often on endoscopy, but very often it may be asymptomatic. An asymptomatic hiatal hernia does not necessarily require surgical intervention. But a patient who has a large hiatus hernia and severe symptoms of GERD is a definite candidate for surgical intervention or even endoscopic intervention. And then atypical symptoms with reflux documented on a 24-hour pH study. So this is why it's important to know which patient gets the pH study and which patient doesn't. So even if there is good response to PPI, if there are persistent symptoms, persistent esophagitis, and the other symptoms which I just mentioned about, like microaspiration, regurgitation, intolerance to medication, complications of GERD, it is better to intervene. So throughout the world, people will say, why do you want to intervene surgically? You can just keep giving them PPIs all their lives. Yes, as all of you know, PPIs are among the safest drugs, most commonly used drugs all over, and very often even combined with the prokinetic, in a combination of a PPI with prokinetic, they're all very, very safe. But long-term use of these PPIs are definitely found to have some chronic effects like chronic kidney disease. It can lead to acute interstitial nephritis. It can lead to Clostridium difficile overinfection of the bowel. It can lead to other complications such as atrophic gastritis, which might by itself predispose to a gastric malignancy, which is far worse. So PPIs used for a long term, like 10 to 15 years, come with their own set of complications. So for that, we advise these patients to go for the workup, which includes an endoscopy, followed by a potential 24-hour pH study, and if they have symptoms of mild dysphagia or odynophagia, we would subject them to a manometry where we test the pressure of the esophagus. And after doing this complete workup, if a pH study shows significantly high reflux above 18 to 20%, in that case, it's an indication for a surgical intervention. So the pH study, as I had mentioned before, will show if it's acid reflux or alkaline reflux. Almost always we see a combined reflux. So among the audience, many of you would be studying for the entrance exams. So can anybody tell me which is more dangerous, acid or alkaline, and why?
The answer is question itself. It should be alkaline, otherwise you won't ask that question.
Is it? Right. So alkaline reflux produces less severity in symptoms, but that can be much more harmful for the esophageal mucosa, and that can produce further chances of Barrett's esophagus. So alkaline reflux, the main pathophysiology behind that, the low LES pressures, as I had mentioned before, is definitely the common endpoint for both. But in alkaline reflux, it happens because of poor duodenal gastric pressures. So there can be further reflux of bile from the duodenum into the stomach. So very often medical gastroenterologists will put in the scope and they'll see quite a bit of bile in the stomach. And remember, bile can irritate not just the stomach, but also the esophagus. Bile is supposed to be beyond D1, beyond the pylorus. It's been beautifully designed that way. So when that pressure is reduced, there's a high chance of alkaline reflux as well. So when there is such severe reflux, you'll have to intervene surgically. So there have been many forms of surgery, starting from open surgery, where patients used to have a huge bilateral subcostal incision, following which they'll have a repair of the fundoplication, repair of the crura as well as the fundus. And then initially they used to do a few thoracotomy procedures. So imagine the patient will be having the pain and the discomfort of a potential cardiac surgery just for reflux. So that was called as the Belsey Mark thoracoscopic or thoracotomy fundoplication. So all that has been given up, and right now I don't want to go into the various types, but the commonly done procedures here are Nissen's fundoplication, where we would be doing a complete wrap of the fundus around the lower esophagus. And the other one is a partial wrap called a Toupe fundoplication, where we will be only doing a partial wrap around the esophagus. And then a few latest treatments have come out with using prosthetic devices. I'll show you a video of that as well. That's called the Lynx device. And then very often for obese patients who have reflux, yes, it's important for them to lose weight through lifestyle and through diet and stuff like that. But still, very often that may not completely relieve their symptoms. So in that case, they will need further treatment surgically for the obesity combined with the reflux. So very often we tell these patients, these obese patients who have severe reflux, we tell them there is a procedure by which you can lose both your weight, and very often they have metabolic syndrome with sugar, BP and all that. You can lose all those problems as well as your reflux. And for that we do a procedure called as a gastric bypass. It's a little radical for a normal patient, but it works wonders for obese patients. So this is a video of the Lynx device which I would be showing you. Volume be put on. So this is just an animated video from the Lynx company. It's something which we don't do. It became a rage when it first came out, and then soon after that it was almost given up.
Into the esophagus. Swallowing forces temporarily break the magnetic bond, allowing food and liquid to pass normally into the stomach. Magnetic attraction closes the LES immediately after swallowing, restoring the body's natural barrier to reflux.
This is just augmenting the lower esophageal sphincter. Instead of using the fundus which is over there to wrap around the lower esophagus, we're just using a prosthetic device around this, a series of magnetic beads called as the Lynx system. So this has its own share of complications. There's a high rate of dysphagia for these patients. There's not enough control as to how loose or how tight it should be. So that's why it's not being done much. And this also requires a laparoscopic procedure. You might as well do the time-tested procedure when you're doing that. So now this is a very important step. The crura is the opening of the diaphragm, the muscles along the diaphragm which allow the esophagus to pass through. So it's an important step where the crura or the diaphragmatic muscles around the esophagus should be tightened well enough to increase or augment the lower esophageal sphincter. And that is what is done by closure of the crural opening. Now, this is one of the advantages that surgical treatments have over endoscopic treatments, because in endoscopy you very rarely get to reach the diaphragm. And this is how it looks intraoperatively. We use a series of proline sutures to close this diaphragm. So remember, when this is closed, there should be enough gap between the esophagus, which you can see over here, and the crura to prevent dysphagia. Because the last thing you want for a patient with reflux is to have dysphagia after the procedure. So this is a diagrammatic representation. So if you just have a look at this, where this is a Nissen's complete 360-degree wrap of this fundoplication, where this fundus is completely wrapped around the lower esophagus. So once I show you the video, it would be easier for you to understand that. So this is a fundoplication where the fundus is not going fully around. So the esophagus is in between and the fundus is on either side. So it's important when we do this procedure, we should have a relatively long esophagus, make sure the crura is completely tightened, and the more floppy, the better, the less chance of dysphagia. So an important association, we've all read about patients having obesity and reflux, and it's been mentioned in the previous talks as well, where they have to be taught to lose weight, to have lifestyle and diet modification. But it's much easier said than done, as many of us would know. So obesity is associated with a nearly 1.5 to 2-fold increase in the risk of GERD symptoms and erosive esophagitis, with a 2.5-fold increase in the risk of esophageal carcinoma. This is a study in 2008. So the main association you'll all have to understand is nearly 50% of morbidly obese patients have severe reflux. And 15% of these obese patients have a symptomatic hiatal hernia. Now this is important for us as laparoscopic surgeons and obesity surgeons, because we do a lot of treatments, we do a lot of anti-obesity surgery. We have to make sure these patients don't have very large hiatus hernias, because the most commonly done anti-obesity procedure in the world right now is a procedure called as a laparoscopic sleeve gastrectomy. And that is a very physiological, very effective procedure for both metabolic as well as obesity resolution. And sleeve gastrectomy cannot be done if a patient has a large hiatus hernia or has severe reflux, as that can further worsen the reflux. So those patients would be offered a form of a gastric bypass, where the pressure is not too high in the stomach. So there's a multifactorial association. Many of these obese patients have a low resting lower esophageal sphincter pressure, and they have a high gastroesophageal pressure gradient. So remember, obese patients have a large amount of visceral fat, and this visceral fat can increase the intra-abdominal pressure tremendously. And when this intra-abdominal pressure increases, it can predispose to further reflux of acid and alkaline. And similarly, this is also the reason why obese patients also have a high incidence of not just hiatus hernia, but ventral hernias as well. Ventral and inguinal hernia is common for the same reason. And then very often these patients have obstructive sleep apnea. They'll have severe snoring and difficulty in sleeping. And those patients will have a higher chance of developing reflux. And then diet. A high carbohydrate, high fat diet can often predispose to reflux. So there are several studies which have proved this. One of the earliest studies by Hampel et al. In 2005. And then there were studies as late as 2019 which has confirmed this by studying for over 10,000 patients. So this is one of the procedures which we've done for a post-sleeve gastrectomy patient who developed severe reflux after that. I'm not going to go into the technical aspects, but this is a procedure where we release the adhesions over here. And this is the jejunum. So a Roux-en-Y gastric bypass is a procedure where we transect the jejunum and reattach it to the stomach to reduce the pressure in the stomach region and to change the metabolism. As all of you know, the reason that Roux-en-Y gastric bypass or any form of gastric bypass works very well for patients with metabolic syndrome is because this basically stimulates a lot of hormones in the distal gut, which completely leads to metabolic resolution. So I will not be going into detail in that. This is called as a stapler, which is used for anastomosing two GI tracts. This is to transect the stomach. So when you make the stomach so small, the amount of acid production also decreases. And then when you attach it to the jejunum, there is no question of a high gastroesophageal pressure, as it all comes down pretty straight. So redo surgeries are pretty complex. That's why not many centers do redo bariatric surgeries, but that is one of our specialties for many years now. So like I told you, a very famous Tamil saying is Oru kallu rendu manga. Here it is Oru kallu anju manga basically. So GERD, hypertension, obesity, type 2 diabetes, obstructive sleep apnea, all these symptoms can be completely resolved with this metabolic surgery, gastric bypass. So this is one of the latest cutting edge that we are proud to have. As you can see over there in the standees, this is how the robot looks from outside, the CMR robot. So this is a procedure called a robotic fundoplication. Again, the patient will just have like 4 incisions, each one hardly 5 mm to 1 centimeter. So I will just take you through the steps without going in detail. This is opening up of the pars flaccida, and you can see these are the robotic instruments, the hook and the grasper with the bipolar. So if you can see, this is the diaphragm right up there. The esophagus comes straight down from over there, and it is tethered to the abdomen by the phrenoesophageal ligaments. So you have to release these ligaments, and you can see here the esophagus is being mobilized. So if you can see, this is the esophagus right here. So it's important to mobilize as much of the esophagus as possible, because in physics you have a law called as the Poiseuille's law, where the higher the length, the lesser the pressure acting on it from outside. So to reduce the abdominal pressure that compresses the GE junction, leading to severe reflux, one of the main tricks here is to lengthen the esophagus. So lengthening the esophagus helps in reducing the chance of reflux. Now this is called as a fundoplication. So the most important step is to release the fundus, and that is what we're doing over here. So we're releasing the fundus from the greater omentum in the upper part by freeing the short gastric vessels which supply the upper part of the stomach. So this is a very tricky step, which is pretty dangerous because the spleen, as you can see, is right there. And an important vessel which supplies this fundus is the short gastric vessel, which is very closely associated with the spleen and the splenic artery. So going in that area is a little risky, which is why not many people venture into this surgery, as it is quite an advanced upper GI surgery. But this is something which we do regularly because we do a lot of obesity surgery as well, which involves operating in that same area. So it's something which we're used to. So now you can see this fundus has to be lifted off. So only if this fundus is lifted off well enough, you can do a proper dissection in that area. So we've seen and we've heard of horrible things happening when you operate very close to the spleen, which is why it's important to have a well-versed team which is experienced enough in this so that we don't have such disasters that happen in that area. So it's important that this fundus over here is as loose as possible or as floppy as possible. Only if the fundus is floppy, it will prevent dysphagia. Because like I told you, if you make it too tight, there's a high chance of dysphagia happening for the patient. So that's basically the fundoplication, where we've completely wrapped the fundus around the esophagus. And this is something which we do on a daily basis or regular basis, simply because of the number of pH studies and manometries that we do. So once again, I'd like to thank you all for your patient listening. And if you've got any queries, any questions, please feel free to ask us.
Well covered, Ani. Subjects are well covered. Very useful to the practitioners also. But one other carry-home message I want to tell you is that there may be reflux without hiatus hernia, and there may be hiatus hernia without reflux. That you have to remember. So just because they say there is a hiatus hernia doesn't automatically mean that the patient has reflux, and then think in those lines. You have to establish by other investigations whether there is reflux, whether the symptoms are due to reflux, or maybe like some ischemic heart disease or something else, or esophageal dysmotility. There may be so many other reasons for pain. So you have to establish that the symptoms are due to reflux, even if there is a hiatus hernia. That is what I want you to remember. Thank you.
Any other questions, anybody? Okay, so because the most commonly done bariatric surgery throughout the world is a sleeve gastrectomy. And many starting bariatric surgeons also do sleeve gastrectomy only commonly because it's the most physiological, where you just cut out a portion of the stomach and that takes care of the patient's weight, diabetes, hypertension and everything. But sleeve gastrectomy by itself is a refluxogenic procedure because the pylorus is still intact. So because of that, there is a high degree of pressure which can further increase the reflux of acid and alkaline contents into the esophagus. So which is why it's very important for us to ask the patients the history of reflux before proceeding with the bariatric surgery. And it's important that most of the bariatric surgery patients get worked up with an endoscopy. So if we find there is a big hiatus hernia or severe erosive esophagitis, we will not offer them a sleeve gastrectomy. So these patients who have undergone sleeve gastrectomy elsewhere, or at that time they might not have had those symptoms. So if they had sleeve gastrectomy, maybe a few years later they come back with severe reflux. At that time we have to do a redo procedure where we reduce that pressure. And one of the simplest ways to reduce that pressure is by doing a bypass, where we transect the stomach above the pylorus and reconnect the jejunum over there. And the shorter you make the stomach length, the lesser the acid that is produced, which can reflux into the OG junction or into the esophagus. So that's why a redo happens sometimes. And not many centers are probably brave enough to do redo bariatric surgeries. So that's something which we do quite regularly, simply because of experience. And that's the reason we do that here. So thank you all once again for your patient listening.